Okay, so the imaging modalities that you can all see are more or less the same that are there in the other systems. X-ray, barium studies. Yes, barium studies is something new. Ultrasound, CT, MRI, angio, nuclear are the same which are there in the other modalities, like you've gone through the CNS system. So more or less the imaging modalities are, you're familiar with the modalities. It's only these barium studies which are something new and which we'll be discussing with you in more detail. So let's begin with the X-ray. You know, chest X-ray, abdominal X-ray, erect, decubitus, abdominal X-ray. Erect, do you know what is erect?
No.
Straight. When you make a patient straight, it is called as erect. So, straight patient and then you take an X-ray of the abdomen. What is decubitus?
Lying on the side.
Lying on one side. Like if I say left decubitus, it means the left side is down and the right side is up. Okay? So if someone says right decubitus, it means the right side is down and the left side is up. Okay? Now the question comes about radiation dose. If you look at this, one abdominal X-ray is equal to 35 chest X-rays. So you can imagine how much the radiation dose is. 35 times the radiation dose when you're doing an abdominal X-ray. Why do you think it is like this?
Because there's more visceral.
Surface area.
More surface area.
Okay, she says there is more soft tissue in the abdomen, so they absorb more radiation. What else? It's actually part of her answer is right, but the main concern is that actually we determine how the X-ray is done. We give the factors. You know, there are these penetrating factors that we use like kV and MAS. Have you heard of this in your physics class? Probably not. Okay, so these are the factors that you see the X-rays have energy in them. So we decide what sort of energy these X-rays should have when they penetrate the body. In chest, we already have a lot of contrast. So if you look at the chest, majority of the chest is occupied by the lungs, which is air. It's not soft tissue, it's just simple air. So there's already inherent contrast in the body. So when we do an X-ray for the chest, we use high kV technique. So the kV we give, kVp, if you can go at home and just Google it, you see that the kV that we give in chest X-rays is high kV. So the high kV means more X-rays penetrate easily instead of being absorbed. So that is why in chest less radiation is absorbed, whereas in abdomen we use low kV technique and more X-rays are absorbed because we need more contrast. In the abdomen, the soft tissues are very much similar, whereas in the chest, the air is already making them, stand apart. There's already contrast between the air and the soft tissues. So you don't need much contrast. The body itself gives you the contrast. So this is the reason why the radiation dose in case of abdominal X-rays, it is 35 times more. Does anyone know how much radiation you give when you do a CT of the abdomen? How much times more? I mean, if you compare a chest, abdominal X-ray, how many times more radiation would you give if you do a CT of the abdomen? Just a wild guess.
6 times more than 65.
250 times. So just imagine you should not be asking, or the clinician should not be asking for an abdominal CT unless it is really needed. You see the importance of radiation. You are giving 250 times the radiation dose that you are giving in an abdominal X-ray. It's already 35 times more than a chest X-ray. So just imagine.
Doctor, again, I didn't understand. So abdominal X-ray is more radiation than
chest X-ray, and CT is 250 times more than an abdominal X-ray.
Oh.
Okay, that is why it is contraindicated in pregnancy, because we don't want to give unnecessary radiation to the fetus, which obviously is still developing. So you can undergo mutation and cancer development is, we don't know. Any cell can mutate anytime. or why do we do X-rays? Acute abdomen. Any acute abdominal condition, like a patient comes to the ER with acute abdomen, he has peritonitis, or he has severe tenderness. The abdominal pain can be because of cholecystitis or renal pain. It can be pain because of appendicitis. A lot of itises in the abdomen. Obstruction, if there is bowel obstruction, can be small bowel or can be distal colonic obstruction. Not indicated for trauma. Why do you think it's not indicated for trauma? Because you'll not be able to tell if there is any visceral injury on a chest X-ray. Understand? You're not able to see the viscera inside. All that you would see is something white or air shadows in the abdomen. So it's not indicated if you have blunt or severe abdominal trauma. In such cases, what would you do?
Ultrasound.
CT scan or ultrasound, which is fast ultrasound. You do a fast ultrasound, which is a quick ultrasound, just to look for free fluid in the peritoneal cavity. So if you see free fluid in a normal person after trauma, that means there is some injury to some organs. Either a viscera is injured or there is injury to some vessel which is bleeding inside. So when you have fluid in the peritoneal cavity, that is the ascites, then you immediately shift such patients to ER, from the ER setting to the ultrasound, or sometimes the ultrasound is done in the ER on the bed there. That is the fast ultrasound. And from the fast ultrasound, once there is free fluid, they immediately do a CT scan and then they identify where the injury is. And if you think or the injury is severe enough, they shift the patient to the OR to sort of do a laparotomy and find out where the bleeding is. So this is the protocol that is done when you have an acute trauma to the abdomen. We'll discuss this in the coming lectures. Okay, so on abdominal X-ray, we have these 5 things. That is the air, the fat, the soft tissues, the bone, and the metals. So these are all different densities. They all give different shades of gray on a chest X-ray or an abdominal X-ray. So what we are doing is, we are trying to separate or to identify 2 separate densities. What I'm trying to convey to you is this is the abdominal X-ray. So if you look at this, there are a lot of things that can be picked up on this X-ray. First of all, if you look at this is the lumbar spine. Why do we see the spine? Because bone is bright. Bone appears bright. There's more calcium in the bone, so these structures, that is the skeleton, appears bright on a chest X-ray. Now the air inside the bowel appears black. Okay. Similarly, if you look at the soft tissues here, you have the subcutaneous fat here that appears somewhat gray. It's less black. I mean, it's not that much black as compared to the air which is there in the bowel, which is overlying. Now, if you look at this, there's another calcific density here. What do you think this is on the left side? Renal stone. Because obviously on the left side you don't have the gallbladder, so you're not going to mix it up with the gallbladder. And on the right side we are not sure sometimes, because if the kidney projects or the gallbladder is overlying this renal, the right hypochondrium, then you are not sure, is it a renal stone or is it a gallstone? Now, if you look at this, there's another structure here. What do you think this is? A stent. You see, there's a stent here. So you can identify a stent which is lying in the right collecting system. Obviously, this stent is in the collecting system. The upper is called as a DJ, double J stent. The upper part of the J is in the pelvis, and the lower part of the J, that is why we call it double J. The lower part is curled up in the urinary bladder. So what do you think is the purpose for this? Why do you put a stent inside it?
Maybe there's a spasm.
Probably there was a stone. There was a stone and it was obstructing the collecting system. So this is a temporary sort of stent inside to drain the kidney so that the kidney does not lose its function. Because if you don't relieve the obstruction, over a period of time, the hydronephrosis or hydroureter would aggravate, get worse, and then the kidney would start losing its function. So we try to prevent this, and we remove the stone sometimes, or what we do is we put a stent for a temporary drainage, and in the meantime, we sort of give the shock wave therapy that is the lithotripsy, the sound waves that are used to break these stones, and then the fragments usually come along these stents, and they, they drain along the ureter, and that is how sometimes, but it depends what type of stone it is, and what the size of the stone. If it's a very large stone, obviously sometimes if it's in the lower collecting system, then they do a partial nephrectomy rather than put a stent in the system. So the main purpose for showing you this is on an abdominal X-ray you will see different densities. You will see air, you will see fat, you will see a metallic object sometimes. A bullet injury might show you a sharpener inside. You might see a stent, you might see calcification. So all give you different shades of gray. So when you are assessing an abdominal X-ray, you have to see why you are doing it. The main purpose for doing an X-ray, you must know what exactly you are looking for. If you are looking for renal stones, that means you must not have colon overlying or the fecal loaded colon overlying the renal areas. Why do you think it is important to clear the colon? You will not be able to see the stones. If the fecal matter is overlying, obviously the stones would be hidden behind the fecal matter. So the technical aspects, you must know why you are actually doing an abdominal X-ray. If you are looking for free peritoneal layer, then you need to do an erect film. Why do you need to do an erect film? So the gas can go up. Gas is going to go up below the diaphragm. Okay, so you do an erect film or a decubitus film if the patient is unable to stand up or cannot sit. So you will just make the side where you think, for example, if it's a duodenal perforation, you'll make the right side up, so you'll do a left decubitus. So you'll make the patient lie for 10 minutes in the left down position and the right side up. So if there is an air, you'll see that air lining along the
Fluid.
the air would rise, and obviously this side is up, so the air would be seen along the abdominal wall. Okay, I'll show you examples of this. So we have to know what we are looking for. Like if we are looking for solid organs, like if we are looking for kidney stone or gallstone, then we need to clear the colon. We are looking for abnormal calcifications. Depends where we are looking for these calcifications. And sometimes we also have to look for lung bases. Why do you think we need to look for the lung bases? Okay, hernia is a good guess. The gas that rises is obviously going to be lying just below the diaphragm. So the bases of the lung are important. Now this is an abdominal X-ray. What do you see here? Now let's see what we can make out of the structure. We already know there's a spine. We already know there's an iliac bone here. This is the sacrum. So you have a sacro-iliac joint here. This is the head of the femur. You see few ribs here. This is the 12th rib. This is the 11th rib. Okay. Now these were the bones that you see on an abdominal X-ray. Now what else do you see? If you look carefully, you see these triangular structures. These are psoas muscles. And if you look at this, you can see, you can make outline of the right kidney. This is a bean-shaped structure here. You can make out the outline here. So you have, if there's a calcium stone line in there projecting over this area, you're quite sure it is renal stone. But what about this area?
You can't see it.
You can't see it. Why you can't see it?
Fecal.
Yeah, there is a lot of gases and lot of abdominal, bowel contents that are obscuring or are making the outline of the kidney difficult on the left side. So this is why we cleanse the bowel before we do an abdominal X-ray. So you try. Do you get my point now?
Yes.
Why do we need preparation? Why do we prepare the patient before doing an abdominal X-ray? Because it depends on what you're looking for. Obviously, if you're looking for intestinal obstruction, you're going to get dilated bowel. You're not going to prepare the patient. He's already obstructed. How would you prepare him? Okay, so we must identify which gas shadows are normal and which are abnormal. So you can have air in the stomach, in the colon, in the small bowel. If I go back, you'll be able to see some air here, some air here. If you see air at the periphery, it is more likely to be in the colon. And if you see the air in the center, it is more likely to be in the intestines.
Doctor, gas, is it an lytic lesion in the light lesion in the bone, or is it gas?
You're talking about this?
Yes.
It's gas in the colon.
So how
It's
could we
the descending colon. It's the descending colon. It comes like this, and then it forms the sigmoid and then goes like this. So this is what I am saying. It depends on what you're looking for. You see, it looks like a lytic lesion, but it is in real sense it's not a lytic lesion. Why? Because you see a lot of other gas shadows like this everywhere. You see one here, you see one here, you see another one here. So these are the lytic lesions. Obviously this one isn't, there's no bone here, and there is no bone between the ribs, so it cannot be a lytic lesion. Okay? So we identify the normal gas in the colon, small bowel and stomach. So you must know the normal so that when you see an abnormal, you immediately identify this gas shadow is not normal. So obviously this needs a lot of patience and a lot of training before actually you identify which gas shadow is not normally seen. So you have to see in case of dilated bowel, you will have another sort of air pattern. And if the gas or air shadow is outside the bowel, what does this mean? Perforation means peritonitis. There is some viscous, there is some hollow viscous which has perforated, and the air has sort of come out into the peritoneal cavity, following that perforation. Okay. You can also see abscess, which sometimes has a upper air fluid level. So you will have a fluid level below and air shadow above the abscess.
Excuse me,
Yeah.
could you go to the previous picture? So the black area there, this is normal.
Yes, this is normal, this is normal, this is normal, this is all normal. Why? Because we haven't prepared the patient. We haven't got rid of the gas shadows which are in the, which are sort of obscuring the system. Now let me show you another X-ray, then it will make your life easy. How do you think this X-ray is?
Clear. No gas.
You see gas shadows?
No.
So this is what we need. You do see gas shadows. What is this?
Yes.
The gas in the stomach. So you cannot stop a person from taking air inside. So you would have some gas in the stomach. But what about the rest of the... You have few gas shadows here. You have few gas shadows in the sigmoid. But more or less, the preparation is such that you can make out the structures very nicely. There isn't much gas in the intestine in this example. So this is a good X-ray if you are trying to do an IVP. Do you remember IVP? Did someone teach you IVP? What is IVP? Intravenous pyelogram. When you are trying to study the collecting system, the renal system. So when you give contrast, you will be able to see the kidneys, ureters, and the urinary bladder. So in such cases, this is good preparation for that. And since there is no gas shadows or there is no fecal content inside the bowel which is obscuring. Why it is what? It's just the projection. But if you look at this, you can make out the kidney shadow. Can you make out the kidney shadow here?
Yeah, yes.
See how nicely you can make it out? You can see it on the other side as well.
Yes.
You can make out the kidney on the other side as well. Now, what about this? Let's see these gas shadows. This one is? Which part of the intestine is it? Jejunum. Why is it jejunum? How would you differentiate jejunum from ileum?
I think the
صراحة شاكر تعجبها.
How are the folds in the jejunum and in the ileum?
More in the jejunum.
More in the jejunum. Okay? So you will have these more folds. If you look at this, these are like stack of coins lined together. You see? These look like stack of coins. More folds in the jejunum. And what part is this?